Good morning. And welcome to UNUIIGH. Before we start, Nadia will let you know the important information that you need to know.
Hi, morning everyone. Thank you for coming to UNUIIGH and welcome to our office. My name is Nadia. I'm the Programs Officer here at UNUIIGH. I'm just going to go through some logistical arrangements. So as you noticed, or you might not have noticed, when you step out of the lift, the toilets are right and left of the lift. The gentleman is on the left and the ladies is on the right. In the unlikely event of a fire, the fire exit is just right behind you, so the staircase is there. And the gathering space is actually down in our parking lot. And a final note is that we have photographs and videos taking sessions throughout the whole session. So if you're uncomfortable or you do not want your photos or videos taken, please let either myself or my colleague Kazima here or Vidya at the back there, please let us know that you don't want your photographs taken. Just to let you know, the photographs will actually be posted on our social media platform. So if you're uncomfortable with that, please do let us know. And I'll hand it back to Pascal, who will introduce our speaker today. Thank you.
I hope you told your bosses you were coming because of your Okay. Good morning and a very warm welcome to UNUIIGH, United Nations University International Institute for Global Health. My name is Pascal Alote. I'm the director here. There are quite a few new faces, actually. So I'll do a very short spiel about what it is we do. The United Nations University is part of the UN system. We report directly to the Secretary General's office through a rector, who is an Under Secretary General. And we were set up primarily as a think tank to the UN. So we work across while our focus is on global health, we work across the UN agencies with a major focus on policy relevant research and evidence generation to low and middle income countries. We are hosted here in Malaysia through a very, very generous endowment by the Malaysian government, which is why we're here. And we're providing lunch afterwards, right? Okay, we'll feed you afterwards. And if you have any questions, then please ask and we can tell you a little bit more about what we do. But just to make sure that our speaker does not remain too nervous, I'd like to introduce Asiya. She'll tell you a little bit more about herself and what she does. Asiya's with us from WHO on loan for 6 months. And it's part of an agreement, an MOU that we have with WHO to work with and support the generation of best practice for WHO on various new aspects of the work that they're doing. It's an opportunity for people like Asiya who have very highly technical, intelligent roles to get a little bit of space to just come away from all of the busyness and just think through what is going to be an advancement on WHO's strategy on community engagement. So, Asiya, please.
I'm intelligent. My 10-year-old daughter would question that. Thank you. So it's really a pleasure and an honor to be here with UNUIIGH. I think it's a rare opportunity that those of us that work in institutions for quite a long time to step out of our daily work and really think about what is it that we're trying to do and how are we doing what we're doing. And I think this is the beauty of an institution like UNU. So I'm at the beginning of the 6 months, which means that I still have a long way to go. And we thought it would be nice just to sort of offer an initial reflection of the experiences and the lessons that we've learned in this area of community engagement. And it's an area that's been coming up again and again for many, many different reasons. And so for the next sort of half an hour, I just want to inject some new thinking, some new ideas, some new concepts, reinforce existing ones that we have. This area is not rocket science, but it is built on scientific principles, and I think that we often think that there is no science to soft skills and the softer aspects of the work that we do in global health. But there really is a scientific underpinning. So I just want to sort of question the traditional understanding that we have. I want it to be interactive, so there will be audience participation, so be forewarned. And there will be opportunities to answer questions as well. So my background, I was born in Somalia. I grew up in England. And I'm married to a Bulgarian, so it explains the way that I look, the way that I talk, and my name, which is sort of confuses a lot of people. I began sort of community development work actually when I was as a teenager, as a youth worker. And it extended right through to working with family organisations in Sheffield, where I grew up, where I was working with refugee communities, and then moved into nursing and health and public health. So I actually am a lot older than I look. And the reason that I cut my hair was that the grey was losing. So when I turned 50, I decided that I needed a new look. So I'll be drawing a lot upon those experiences. So, just a question: what kind of background are you from? How many of you are researchers? Put your hands up. How many of you work in policy at the policy level? How many of you are clinicians, work at the clinical level? Community, health promotion. Have I missed anyone? Some of you. Have I missed anyone? Educators.
Civil society.
Civil society. Okay, great. So we've got a good representation. So engaging with communities. If you read the literature, particularly literature that's related to community engagement and health, we've found that engaging with communities consistently and at scale remains a challenge for health programs and planners. And this was a paper that was written in 1986 that reviewed 200 case studies of communities, and it says lessons from community participation in health programs. At the moment, there are people doing case studies on community engagement. And if we compare the findings from those case studies and the findings from today's case studies, we would see a remarkable level of similarity in terms of the recommendations that they make. So there's a consensus about sort of the importance of community engagement, that we need to do it, that there are lots of best practices out there from the past and current, but how do we turn that into making our understanding of community engagement work for us, so that we start to see a difference in the way that health services and programs are designed, developed and delivered. And we still struggle with that. For WHO, the 2014-15 Ebola outbreak brought home to us the enormity of the importance of understanding communities' role and responses and social context and culture. And so we know we have to do differently and do better. But if we look at sort of the usual experiences, we still find that communities are involved too late or too little, that there's marginalisation of vulnerable groups within communities, that somehow we come with a paternalistic and educating approach. Somehow we need to educate them, we need to behaviour change them, we need to do something so that communities start behaving differently and thinking differently. And in some of the programs, we see that community systems and infrastructure are bypassed and often ignored. But we do want communities to be able to contribute. We do want to proactively consider their needs and address the needs of marginalised and vulnerable groups. We do want to listen, and we do want to build relationships. There is a desire to do that. So what is it that is getting in the way? And I think there are many factors, but we have to recognize that the world has changed, and how we conceptualize community in the 1980s, and when Alma-Ata conference in 1978 sort of identified the importance of community participation and involvement in health. It's a very different world that we live in. We have communities connected across the world. We have virtual communities. We have the ability to be able to go into the Sahara Desert and take a snapshot, and within minutes that photograph is sent to a different part of the globe. And when I was growing up, I remember I spoke into a cassette recorder, and that cassette recorder was hand-carried by people who knew my family, who then took it to my grandmother, who put it in a cassette recorder and listened to it. And then she recorded an answer, and it was sent back to us. So that's the world that I grew up in and remember. But the world that my daughter is growing up in now is very, very different. And I think how we understand what community is and how it works, we need to factor that into consideration. But there are ways of thinking about community that informs how we currently understand it, how research is done, and how we practice community engagement. And when it comes to the health sector, I think we need to recognise that often there's a dominance of a biomedical approach, that the ones who make decisions about whether to invest in community engagement often may not understand what it is, but their world is very much a biomedical world. We have an institutional culture. Health systems have a culture of their own, which is informed by the way that the health workforce, their professional education and training enables them to work in that particular culture. And there's been numerous studies that show that when medical students enter training, they come with a lot of compassion. But yet when they finish their medical training, they have less compassion, but they think that they have more compassion. So they believe that they're more compassionate as a result of their medical training, and yet it's shown that their levels of compassion have actually gone down, and that's as a result of the way that they have been trained. There are also donor fundings and priorities and agendas around community engagement. That also determines what kind of research gets done. And often for those of us working in community engagement, it feels a bit like that we're pushing against a heavy boulder. But we still continue, because I think that despite the overwhelming issues and barriers, community engagement is one of those areas where it has a huge amount of potential, and that potential is what I'm going to be talking about. So if we take all of those factors that influence the way that we think about community engagement, it often it forces us to have a particular mindset and paradigm. And this cartoon is particularly important because you have somebody who's dropped a coin on the floor, and the police officer is saying, "Did you drop it here?" And he says, "No, I dropped it two blocks down the street." The officer says, "Why are you looking at it over here?" And he says, "Because the light is here." Yeah. And I often think that when we think about community engagement, because of the way that we understand and think about who community is and what community engagement means, it forces us to look at it in a certain way. And so we have to be conscious about how our mental models, our unconscious paradigms, get into the way of thinking about the science of lived experience. That's evidence too, and there's a lot of data in how we experience and interpret the world that informs how we act in the world. Indigenous knowledge, common sense and good manners. So for me, when I think of who I am and how I engage with others, it's not only how I see myself, but where I come from, my culture, my upbringing, how my mother raised me, the social norms, all of that influences how I feel about myself and how I think of myself and how I relate to other people and other communities. And so when we look at community engagement and those of us that do community engagement and members of a community and how they engage with each other, we have to think of all of these in that particular moment. But I'm also a member of a professional community. I'm also, as a mother, I'm a member of a community who had children. And when I gained weight, I became a member of those who wanted to lose the weight that I gained because of my pregnancy. And so the important point here is that we are members of multiple communities all at the same time. And those communities shape us, but we also shape how that community works by what we contribute to it. And so when we're moving towards a definition of community engagement, we have to take all of this into consideration. Those communities, we live in multiple stories. So the stories I tell about myself and who I am, and I make sense of that, are all around the kind of stories that help me make sense of the different world, the different social worlds in which I live in. So, in 2019, we have some opportunities to rethink of what community engagement is and how we need to be approaching it. There's an emphasis on primary health care, towards universal health coverage, in achievement of the Sustainable Development Goals. And this era is very different to the Millennium Development Goals, where it was all about vertical programs. And that sort of focus on sort of vertical programs and curing disease, again sort of formed how we think about community engagement. And so it's an opportunity to sort of revisit community and what we mean by that. We also have the WHO framework on integrated people-centered health services, which was adopted by member states in 2016, which also includes Malaysia. So we're all behind people-centered health systems, people-centered health services. And so in March 2016, with the WHO African Regional Office, following the Ebola response, we worked collaboratively together and said, if we were to learn all of the lessons from the past, if we then were to look forward, what is it that we need to be doing to institutionalize community engagement in the way that health systems work? And so from that meeting in March 2017, we co-developed a framework that aimed just to do that. And in the development of that framework, we drew upon a scoping and mapping of community engagements and interventions and practices. We interviewed WHO program staff who work on programs where community-based interventions and community engagement is important. We commissioned a synthesis of lessons learned. We also assessed the organisational capacities of health promotion within the WHO country offices. And we also looked at WHO collaborating centres to get a sense of who was working in these areas. And that all sort of fed into the development of the framework. What did we find? We find that a community engagement model that's sufficiently robust doesn't exist that takes into account the multiple entry points that communities have with health systems, and that recognises the relative levels of power, voice, impact and opportunity for knowledge sharing and relationship building inside health systems, between health systems and communities, and within communities themselves. And the current research ignores the community of health professionals. The current research sort of focuses on education and information and doesn't deal with the emotions or feelings component of engagement. and that there's insufficient attention being given to the development of engagement processes that support effective sustainability of practices, and that this community engagement literature hasn't sufficiently investigated the impact of trauma histories on the quality of engagement. And we know that in families where trauma has occurred, or in communities where trauma has occurred, where in countries where there's civil war or conflict, how people relate to each other will be affected by that experience. And that also needs to be factored into the way that we design our engagement interventions. So we looked at, with Afro colleagues, health systems and communities, and what we were particularly focused on was those interventions. Where are the interfaces between communities? And we recognised that the lens that we were bringing to this was that we needed to focus on how community engagement could improve the quality, people-centeredness and resilience of health services, but in a way that also contributed to the resilience of communities. And we recognised that there were multiple communities that were systemically linked inside the health system and outside the health system, that there's interdependence between health systems and communities. We realised in the Ebola response that how health workers and how health services are designed and implemented has instigate a community reaction to that. So there's an enormous amount of power to be able to influence how communities respond. And there's also power issues, both within health systems in terms of the different cadres of healthcare and between various groups within communities. And we recognised that it needed to be informed by science and research across disciplines. Important point, health systems are not gender neutral. Health systems are not without cultures, and we have to look at that when we try and see how we can develop relationships between service providers and communities. And health systems are living human systems. They're people. And we often focus on what the people in health systems do rather than who they are and how they do their work. And so we have to sort of begin to look at the human dimension of health systems. And we have to look at health systems in the wider social, cultural, economic, political and historical context in which they are situated. So the working definition that we came up with, and we looked at various sort of definitions of community engagement, and it's being tested and validated in different ways. That community engagement is a process of developing relationships that enable stakeholders to work together to address health-related issues and promote well-being to achieve positive health impact and outcomes. And that the stakeholders comprise of multiple communities that include community members, patients, health professionals, policymakers, and other sectors. And that the desired relationships are characterised by respect, trust, and purpose. There's a reason why we do community engagement. And that health-related issues could include public health events such as emergencies. If we conceptualise and think of community engagement in this way, it means that we need to look at different theoretical foundations. It means we have to look at a different set of interventions. And it means that we have to develop a different set of metrics, because we're talking about complex systems. We're talking about engagement as an ongoing, dynamic, unfolding process. And so looking at behaviour change and messaging and information is not going to tell us how we need to be doing community engagement in a way that builds trust between the communities and the stakeholders that need to work together. So this is the model that underpins the framework. And it focuses on relationship building, on process, what will enable connection to occur, how to build trust and mutual respect, all towards co-design, co-development and co-implementation. And that is specific. What does it look like practically? It means looking at strengthening relational feedback loops at different levels of the health system. And this could equally be applied to how do you strengthen relational feedback loops within communities. But we're looking at sort of the interface between systems and communities. And so interfaces occur at health functions. If you have surveillance officers, you have community health workers. If there's an emergency and you have rapid response teams, that's an interface point with communities. And so we have to take into account of how relationships are being formed or damaged through the interactions between health workers who interface with communities. There's also in health settings, in health facilities, interaction and engagement happens there. So we need to be looking at that. And social accountability mechanisms through hospital boards, health committees, citizen hearings, working through civil society organisations. We have to look at all of them in totality, not just one at a time, in order to determine how can we approach this area coherently in a way that builds trust at all of the different strategic interface points that communities have with the health systems and health services. So, a couple of examples that I just want to highlight. Embedding community engagement into surveillance functions during the Ebola response. And this was a proof of concept project. And what we wanted to do was use science and theory and practice to help frontline staff build trust with communities. And we knew that there was an issue in Liberia, Guinea and Sierra Leone. We had received information from ministries of health, agencies. We'd looked at sort of the current training that was being provided. And we knew that there was a gap that we needed to fill because we wanted to address this issue of fear. And when people are scared, we interpret information in different ways. We have difficulties in prioritizing because we have an emotional response. And yet when as health workers we are trying to give people factual information about disease, that factual information will get lost if they don't trust the person who is providing that information. And so we wanted to see how we could build that capability to build trust within the frontline staff. And so what it needed was global and national collaboration. And so we got the opportunity to bring together within WHO the surveillance colleagues with the community engagement and social mobilization team to draw upon the disciplines that could help us understand how we needed to build trust between frontline staff and communities. We identified a country need, we had to make sure that it was technically relevant and coherent, and we had to build in processes of iterative learning from the very beginning when we wanted to design the content of the training for frontline staff in countries. And that meant bringing people from the countries, disciplinary experts together to say, here's an issue, how do we deal with it together? At the national level, it meant collaborating between WHO, Ministry of Health, and within the Ministry of Health, it was bringing the health education together with the disease prevention and control team. It meant working with the National AIDS Secretariat, UNFPA, Norwegian Refugee Council, UNICEF, and Focus 1000 was a monitoring and evaluation institution locally that helped us understand what difference it could make. So we had international facilitators support working with national facilitators, and in the end, 656 frontline staff were trained in integrated cohorts. So surveillance people were trained with community and religious leaders and social mobilizers and Ebola survivors, because we had to bring the multiple perspectives together so that they could each understand what their perspectives were and what they could learn from each other to make sure that the communities were were engaged. There were products that were developed, a facilitator's guide, but the thing that made the most difference was that it wasn't about PowerPoint presentations. It was enabling facilitators to facilitate a learning experience that met a need that the surveillance officers had to know and understand how better to engage with others. So every cohort was different, which meant that the facilitator had to adapt and design the content from the needs that emerged from the participants themselves. And it was an experiential design. We focused on understanding their context. We spoke specifically about the emotional side of engagement, understanding reactive and receptive states, listening from the other person's perspective, what builds and makes trust, how to manage conversations. And then we asked them to develop a personal engagement plan where they identified a few key things that they wanted to practice and change when they went back to their surveillance functions. And so very quickly, I just want to give an example of the importance of reactive and receptive emotional states. So I'd like to invite you just to close your eyes. You can trust me. You're in UNUIIGH, we're a trustworthy institution. And I want you to think of, just breathe deeply, sort of breathe, take deep breaths that come from your stomach area. And I'm going to say a word, and I just want you to pay attention to how you react to that word. No. 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 Keep your eyes closed. Take a few more deep breaths. I'm going to say another word, and just pay attention to how you physically respond to that. Yes. 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 And open your eyes. Dr. Daniel Siegel does this much better than I, so if you Google him on YouTube, you can have a much better explanation. But between the first and the second, how did that feel? How did the first one feel? Sorry? Negative. Yeah. Irritating. Yeah. What else? Sorry? Offensive. Yeah.
I was rejecting it.
You were rejecting it. Yeah.
Increasingly aggressive.
Increasingly aggressive. Yeah. How did you feel physically? Sorry?
Disrupting my peace of mind.
Disrupting your peace of mind.
Yes.
Tense. Yeah. Angry. Okay. Limiting. Yeah.
Stressful.
How did the second one feel?
Make me smile.
Made you smile. Okay.
Encouraging.
Open. Yeah. Okay. Isn't it incredible what reaction one word has? Yeah? And I think we often forget that as we are interacting with each other, as we're involved in daily conversations with our families and with our colleagues, we are in fact experiencing physiological responses to the conversations and the situations that we have around us. It's just that we don't pay attention to it. But imagine what would happen if we did pay attention to that. It would mean that we would be able to manage and regulate how we feel so that we put ourselves in the kind of receptive states that would enable us to keep that connection with other people. And what was came out of the training in Sierra Leone was that after the training, people remembered emotional states, receptive, reactive states, and they said, am I reactive? Am I being reactive? Am I being receptive? It really impacted them. And it shows why we do need to take this into consideration, because it has profound impact on changing behaviours, but through changing behaviours, not by telling people what to do, but by preparing yourself to engage in conversations and interactions that enable receptivity in others. In fact, there's been a growing body of research that shows that cognitive decision-making that happens inside our individual brains also takes place in interpersonal space. Imagine, decision-making takes place in interpersonal space. That means that somehow, just by being closer to people, there is an exchange of information happening that we're not aware of in the space between people. So when we talk about how do you identify what trust is, you feel trust when you meet somebody for the first time. You know whether you trust or distrust that person, don't you? And you can't put it into words, but there's something about it that you're picking up or sensing that tells you this person is trustworthy or not. We also know that, particularly from the education sector, that how we talk how teachers talk to children has the ability to raise or lower their IQ levels. We also know that the interaction between spouses can contribute to heart attacks. Because go back to that stressful state when you're engaged in conversation. And if you have patterns of conversation between spouses that are negative and you're not getting along and you're constantly exposed to that, it increases stress levels and your body adapts and of course it contributes to heart attacks and things like that. So we have to be mindful of the research that's out there that's sort of telling us that it's important to pay attention to this dimension. So what were the results sort of before and after the training? And it was only a one-day training, one day. But we knew that there was high tension and mistrust between communities and frontline staff before the training, that the communities viewed frontline staff as benefiting financially from the Ebola response. The interactions were one of community resentment and mistrust. Communities are not always feeling that frontline staff had their best interests at heart. And after the training, what we found was that we had incidences several weeks a month after the training where surveillance officers were using their own money to pay for telephone credits for families who didn't have the money to be able to make telephone calls. They were following up on social services and the NGOs that were said that they were delivering water and food to quarantined households. The surveillance officers were the ones who were following up and chasing them. So it has the ability to be able to change relationships in a way that we couldn't have imagined. So, very briefly, that sort of surveillance function. We also looked at introducing the community engagement framework through a national health program, malaria in Rwanda. And so what we did was work with the Strategic Technical Advisory Group on Malaria Eradication, which was set up to advise WHO on whether it's possible that malaria could be eradicated, to look at community engagement. And it was an opportunity to work with the SAGME members and other agencies to see how we could look at what is it that we need to be thinking about in terms of community engagement and malaria. And so from the first SAGME meeting to the final SAGME meeting, we shifted from talking about mobilization and participation and ownership to engagement, dialogue, trust, relationship building. And we worked with Rwanda to see what could we understand about the relationship that the malaria program has with its own stakeholders using the framework and the assessment tools. And so it was tested in 4 districts. And we found that the community engagement practices in the 4 districts were all different because context is different, relationships are different. Where a top-down model dominates, the incidence of malaria is highest. where communities are active, malaria incidence is lower. The lowest levels of malaria is where collaboration is the greatest. These were just observations. We're not making causal inferences here, but we're just sort of stating what we found. There's a disconnect between those who plan strategy for malaria control and elimination and those who implement the practices and procedures. There appears to be no mechanism to share learning and best practices at each level and across districts. And although community health workers are uniquely situated to serve as liaison between community members, other stakeholders and malaria program staff, there was very little sort of lessons learned from the community health workers going up to the decision makers. When we put it into a relationship map of the 4 districts, and the directions indicate sort of the flow of information, we see that there are some places where you've got information exchange which goes both ways. You've got some relationships where it's just top-down, information is being given. But overwhelmingly, how national level communicates is really instructing and telling the districts and those that are implementing what to do. And when it comes to planning is done at the top and implementation is done at the bottom. And somehow there needs to be a more co-development introduced into that, and the communication flow needs to be sort of more bi-directional. What's interesting here also is that there is no horizontal learning between districts. So how can solutions that and what's worked in one district, how can that be shared with other districts? And sort of that sort of horizontal flow that needs to be encouraged supports learning, it supports, it strengthens the entire system, but we have to sort of look at relationships maps to find out where relationships are working and where it needs to be strengthened. Another example, yesterday I was with the Southeast Asia Observatory, which was set up to look at sort of, it's a research platform which comes underneath Monash University. If you want more information about this, Pascal, I'm sure, will be happy to answer those questions. And in fact, Pascal was one of the key people who set up the platform. And the way that the platform was set up actually embeds an engagement process from design to how it's functioning now. And I think the lessons that could be learned from that experience in Johar is also an example of where engagement processes and practices need to be thought about as you design and implement an approach or an intervention or a practice. What all 3 examples have in common is that we shift from a transactional relationship with communities to a relational approach to communities. And why relational approaches are so important is that we think that we are not connected, but human beings are interconnected in ways that we're only just beginning to measure, and some of the research that I spoke about points to that. We do affect each other's biologies. We do affect each other's physiologies. There's no getting away from that. We've all heard the phrase, no man's an island. But we are all interconnected, and that interconnection needs to work for us rather than against us. And I think there's a growing body of research which is interdisciplinary that actually helps us understand how the way that our brain develops or our brain function is influenced by our interpersonal relationships and our environment. And if we adapt and change those interpersonal relationships that support coherent brain development in children, you would, it's a way of parenting that actually empowers parents to help their children move through the various stages of development. And I can give you numerous examples of that, but from my own parenting experience, but I won't go into that now. But human relationships are key to understanding how we can better engage with communities. And this picture is just to illustrate that in health system strengthening approaches that we've had so far, we look at what people do, we look at functions, we look at the things that we can touch, see and feel. We don't look at the human dimensions of health system strengthening. And it's a bit like when you look at the ocean and you kind of see the ocean and if you don't know what lies in the depths of the ocean. But if you're a diver, there's a whole world there that we need to understand and explore. And the similarity is the external world that we live in, but also the internal world that's sort of within us, that it's how we encode and interpret our experiences, and how we begin to sort of connect how we think and how we feel and how we act, rather than just focusing on how we act. By changing and shifting how we feel about things, how we think about things, we are able to change behaviours. In actual fact, our behaviour is a natural extension of how we feel and how we think. And so it's important to bring that dimension in. And community engagement could be a pathway to realising people-centred health systems if we think of human beings in this way. And it requires a different cadre of researchers able to develop different kinds of research. Because if we're researching community engagement from the dimensions of human engagement and human development, we need to ask different kinds of questions and look at different kinds of interventions. So what are some of the practical considerations when it relates to what's the difference that it can make? So when we look at mainstreaming engagement in health systems as a prerequisite to being able to engage with patients and their families and communities, we need to look at the way that interprofessional teams operate. That if you bring together clinicians and epidemiologists and lab people and whatever group health cadres that need to be brought together to address a particular health issue, it's the team that we need to focus on. And in order to activate the intelligence that lies in those individuals, there has to be compassion, empathy and rapport between the individuals. It's not just about what we know, it's about how we are able to contribute to a collective understanding of what we need to do. And that means that some of these applied communication skills need to be built in. Listening, observing, sensing, speaking, feeling, because all of this influences how information is shared, what kind of information gets shared, what sense is made out of the data and the information. It affects how we make decisions, how we understand and manage context, how things get done, and also how we learn, which contributes to the way that the system performs and the way that communities and patients experience services. So this is a way of looking at sort of linking the kind of ways in which we can build the capacities or skills in our health workforce to be able to work in ways where engagement becomes part and parcel of the way that they do their work. So engagement being purposeful and intentional, it will require interventions and tools that build social, emotional, relational skills and practices, interpersonal and team communication skill methods, tools and practices, and also how do we integrate qualitative methods and tools. So it's a combination of interventions that actually go into this sort of engagement competency. And it needs to be supported by leaders, a leadership that recognises that developing these capacities and competencies are important and create the opportunity environments in which people can begin to think differently, feel differently and behave differently. If we had this, then we would have reflective practitioners at different levels of the health system, able to work in ways that are compassionate to themselves, that they take care of themselves and others, and be able to respond to the needs and preferences of the people that they're trying to support. We would have managers being able to embed and sustain core engagement skills and methods into job functions, into team work, project management, into services and programmatic decision making. And we would have a leadership that is sort of focused on value-based relationship approaches that look at the organizational culture and create an organizational culture that support collaboration and coordination. So rather than just talking about that it's important, actually doing it. And this would lead to people-centered and community competent services and programs. And if we were to see this, the rationale is that you would see changes in the system itself. So this is the idea or the rationale behind it, and one of the reasons why I'm here with UNUIIGH is to sort of look at the theoretical foundations for such an approach and what it would mean, and pull together the evidence for being able to develop a research agenda that really speaks to a more human-centered understanding of what community engagement is. So this is my final slide. Community engagement is a way of doing business, not a way of changing other people's behaviour. I think community engagement is often seen as a means to an end, but engagement itself is an intervention in its own right. We have to define what community engagement is depending on each context. There is not going to be one definition that is applicable to every situation. We've looked at it from the perspective of community engagement as a way of leading to people-centered, quality, resilient health services. We know that the linkages in systems are formed by strong connections build engagement between health systems and communities. We're looking at the linkages between the different parts. And that coordination, collaboration and empowerment are shaped and reshaped in our relationships. Our relationships determine empowerment. And if we take care of our relationships, then we are able to work in ways that empower not only ourselves but others. And the role, skill sets and competencies of engagement practitioners in health systems and in communities are going to be critical in the SDG era. And community engagement research needs to be linked to national health and development, be country-led and owned, and supported by the best available interdisciplinary science and interventions. Thank you. I know I've taken longer than I thought. Are there any questions?
Yes, you're dying to ask the question.
Thank you, Aisha, for bringing me. So I come from the health systems from the Ministry of Health, so it's a bit difficult, but we do know the direction is actually community engagement. I think the question that I want to pose is who is responsible here? Because, well, we're from the ministry, we have our facilities, we try and do outreach programs, and as you rightly pointed out, we're not having this horizontal, so in different states, like yesterday we were at SICO, it works in SICO because there's engagement there, but then until yesterday I didn't realize how much of community engagement that you've done, and this information is not being informed even in the state of Johor. So whose responsibility is it? I know there might be some NGOs here, but again at an international level or even in Malaysia, we are struggling.
Okay. I think that's, if we could solve that problem, I think we could do much more in community engagement, because it's a function and it's a process, and we need to recognise that health systems, as I've spoken about, we have a certain culture and a certain way of interacting. So you actually need to have community engagement practitioners that begin to substantiate a different pattern and a different way of interacting inside health systems. So this cadre of engagement practitioners actually needs to emerge, because what it does is it takes you need people that are informed by multiple disciplines. You need people that understand the health system context. You need people that are credible. And in some countries, it's been taken on board by the quality department, because if you're looking at improving quality of services across the board, that may be a natural entry point for beginning to engage with multiple internal stakeholders in the health system and working with them to begin to embed the knowledge and the skill set and the tools that are required to begin to embed a different way of thinking and working. Because being able to engage with patients, their families and communities, you've got to build that into an existing system, and you've got to have people to be able to do that. And I think I'm going to put it back to you and say, knowing what you know, what is the best way of taking this forward for you and for Malaysia? Who needs to be sitting around the table? Who needs to come together to address this? I think we need to think about both inside health systems and inside communities. And in communities, it may be civil society groups and other agencies where they have a mandate and a remit for community development and social development. But I think the same knowledge and approaches and interventions could be also adapted. But I think we need to work inside and outside to be able to make those links.
To that?
Yeah.
So correct me if I'm wrong, but my sense of the discussions in WHO, which are specifically part of your portfolio, is that this is a broader approach that the organization wants to make a part of the universal health coverage system right the way through. So in some ways, my sense is that what your outputs are, and given the very high level support you have within WHO as well, that this is something that also needs to come from the top. It's not just about service provision, it is about everyone within the health system. So if this is the way that the organization thinks generally, then it will, it needs to walk the talk.
Yeah.
And if, I can think of individuals within our systems who should be thinking about all of these things.
Yeah.
So a very concrete example, for instance, might be, and I was thinking of one of the examples that was given in SECO yesterday. So the staff had said, to one of the questions that was asked, the staff had said, when we go, so sometimes when we go out to the community, there are things that we can't address, so we hide behind Daniel and Pascal. Do you remember that comment? Because we want them to be the ones to give that information to the community. And in thinking, just reflecting on that comment in particular, it really brings to mind the fact that if you're engaging with people, because of the example of some people just give you a gut reaction that you whether it's inherent trust or whatever it is, that different messages are heard by different people, and so even at the highest level of our governments, it has to be very clear that for any particular message, for any particular engagement event, there's some things that I don't want to hear it from this person or that person. There are things that my dad can tell me that if my mum told me, I'd wring her neck. But but to even begin to contemplate that level of sophistication, we all have to be thinking in this way, that, you know, standing up to give a particular speech or whatever. I may want to do it because it will make me seem very important, but it may not necessarily be me that the audience needs to hear it from. It has to be, so we have to be intelligent enough to think, okay, and we are engaging. We have to think through at all levels exactly what it is we want to convey, what we want out of this relationship, and think through not just the content, which we tend to do often in health. We think about it, this is what needs to be said, but how it is delivered, who delivers it, all of that is a critical part of the puzzle. This is my understanding.
Yeah.
So the outputs from here are not just about the specific systems-related thing, but about WHO itself, how it is going to transform in the way that it's thinking, so that this then also becomes a way that it engages with member states.
Yeah.
So you've got a big job.
No, I don't know. But talking about transformation, I mean, I think it's there's an opportunity here to really look at the human dimensions of health. And as an organisation, we are going through transformation at the moment, and with the current Director General, Dr. Tedros, one of the first things that he did when he came was say, everybody is able to communicate with anyone else. I don't want sort of people going through hierarchy to get messages up to leadership. So he instituted an open door policy. So every Thursday afternoon, I think it's maybe once every 2 weeks, I can't quite remember, but you can make an appointment to go and see him. Anyone can. He is started some kind of a lottery where a member of staff is pulled out and he has lunch with them. And he sits with us and he asks us, well, how's it going for you? What's happening? And I think this sense of leadership, knowing exactly what people who are doing the daily work are going through, is important, so that they begin to sort of model the kind of engagement that they expect from everyone in the health system. And I think it's particularly challenging if you have managers who have been trained in a hierarchical approach where you kind of, I decide, I will consult with you, but ultimately I decide. You know? And I think changing that culture will require leadership to address it. And it will also require individuals and teams who have that expertise to begin to start embedding those particular knowledge and skills and tools, so that those who need to engage with others are able to have different ways of doing that. But I think you're right, it's through the entire system. In health, I think that serviced experience is what sort of crystallizes how well the health system is meeting the needs of not only the health workforce but also the service users and the communities. It's that, how is that service experience felt and going, that gives us clues about what else needs to be done to ensure that the system is orientated and that people who work in it actually understand the values and connect to the purpose and mission and objectives and are able to make decisions every day that guides them towards those sort of higher level ideals and goals. But leadership has a huge amount to play in making that work.
Yes. So I'm just wondering, because the examples that you posed just now were in places of crisis, so like the malaria, Rwanda.
Sorry, do you mind standing and
Yes, sure.
directing?
Yeah, sorry.
Tell us your name and where you're from.
My name is Baishu and I'm from Ideas. It's a public policy think tank and I work specifically in health policy. The examples that you posed were specifically in a crisis situation where you've tried to introduce this model. And I was just wondering if you had any idea, any examples of So introducing this model in an existing national health system, and if you have, sort of what kind of challenges you've sort of faced with that.
The example I gave for malaria, there's a national malaria program. Yeah. So if you looked at the relationship map, that's in a program where it's routine. It's dealing with malaria control and elimination. So yeah. So where we are with that is we've uncovered data and evidence that tells us that there are places where engagement is working. There are places where it needs to be strengthened. And so the next step is using that to develop a set of interventions that addresses those issues with the local team. So we're at that stage where we'll move into that.
Malaria is the case that
malaria, yeah,
other aspects.
yeah, it's the first program. It's the first program that is doing it. But I think if you can look at existing good practices and use the framework to identify which bits of it were present and which bits of it led to its success. Because if you look at sort of the case studies, they will tell you what worked. They will tell you what the outcomes and the outputs were, but it's the contextual relational pieces that often don't get described, and usually they're the ones. It's a champion who is supporting this way of working, who has a particular skill set or the ability to be able to identify who they need to bring on board, and that sort of relationship building piece, that awareness of local context and dynamics, and being able to manage and navigate that with the stakeholders is not sort of very well described in literature. Wouldn't you agree? Yes,
Hi, thank you for your talk. I'm Sulin from Penang Institute. I'm also similarly to Vaishu, a sort of analyst looking at public policies with a specific interest in the mental health field. I just wanted to raise a question about how this community engagement model could be built into delivery of mental health services. Last year, maybe a couple of years ago, I attended a workshop at UNU as well in this room, which was looking at psychological first aid in the context of disaster response, disaster and risk management. And it was a really good workshop, but it got me thinking about how community services with regards to mental health are actually delivered in Malaysia. And from what I understand from my reading of it, the approach is still very much a biomedical approach where teams from hospitals would be going to homes to kind of ensure that patients follow up their treatment and such. But I feel that there is perhaps an element lacking in terms of the cultural sensitivity, and also how, as we talked about, as you mentioned earlier, the people-centered approach is not quite integrated into this. And so I'd like to hear your thoughts on how we can start to incorporate that model. Like, what are the first steps that you would need to look at? Is there a framework that WHO has developed that we could perhaps reference, or best standard practices in neighboring countries?
There is a mental health program within WHO, and there are a set of guidelines that are being produced. And if you look at there's a pyramid, and usually if you're unable to resolve issues at the sort of the local community level, they tend to escalate until it becomes an acute situation. And so if we look at community engagement as a way of providing a way of interacting with communities and with people in ways that support well-being, that's a way of integrating it into the existing work that service providers have. or people who enter communities are able to sort of work in ways that produce health and well-being. We've had one example in where is it? In Jordan, where two of the scholars that I work with a major non-governmental hospital who were mainly dealing with refugees, and the health staff were burnt out. So they themselves were suffering from stress, at the same time as dealing with patients who were refugees, and of course also came with their own experiences and mental health issues. And so they worked with them to begin to look at how they could address the health and well-being of the hospital staff, so that they were then able to provide the environments and a way of engaging with their patients, so that they were able to deal with anxiety and stress without sort of coming in and saying, now we're going to do mental health work, now we're going to do a psychosocial intervention to you. You can actually do that through the way that you do clinical interviews, through the way that the receptionist greets someone at the door, through the having tools and toys for children to play with, through the way that you interact. There are lots and lots of opportunities for integrating psychosocial aid into that process, but it has to be conscious.
Yes.
Until it becomes unconscious.
Yeah.
And I think that's what we
Exactly.
that's an opportunity there.
Yeah, so I think to kind of recapture what you're saying, it's to kind of integrate it into the environment rather than medicalizing or putting a label on we need to do this particular thing.
Yeah.
And I mean, what you mentioned in Jordan is great, but I think what would be helpful for me to get a better sense is to see if any country has actually put it down on paper, if you see what I mean, like what are the best practices for this to be embedded and sold in, because I think one incredible challenge that we have in our country is being able to develop practices in that sense. A little bit ad hoc in terms of how, to visualize is one thing, but to execute is another.
I agree, and I'm going to challenge you a little bit there, because if we look at the way that we've always done things, then how can we expect to do them differently in the future? And I think this is where research comes in. So taking research and translating it into evidence so that you can then make policy recommendations is the process. But we're not using our own research to inform the kind of research that helps us generate that evidence. We have to wait until the business sector does that. So if you look at being recorded. If you look at sort of how the health sector, really we don't innovate because we don't use our own knowledge.
Yeah.
We generate knowledge that the business sector uses, which we then say, oh my goodness, the business sector is doing so wonderful, why can't we learn from them? So this whole issue of human-centered design, for example, or how can we make our workplaces more human, the research is coming from health. So why are we not engaging with those interdisciplinary researchers who are coming up with the research and then saying, how can we use that and embed it in the way that informs our practice and helps us generate the evidence that we need? The whole sort of social marketing era. Do you remember the social marketing era where it was all about integrated marketing, communication? It went through the private sector and then it came to the health sector, and then suddenly we went into social marketing. But by that time, the private sector had moved on to something else. And I think we need to sort of create our own knowledge and use the research that is being generated by us. We're not looking inside our own system to how we can change it so that we're able to do something differently. We're expecting others to sort of inform us, and then we take that and then we develop guidelines. But I think we need to be more critical and we need to be more innovative, and that is only going to come from outside traditional institutions. So it's people like yourselves, it's researchers, it is countries who are really struggling with issues that they need to address, that need to find those solutions.
So, hello and thank you for your presentation. I am Estelle and I work for MACMA, so it's a non-for-profit cancer-related here in Malaysia. So my question is more specifically about the front line, so how to make sure that you engage the front line with let's say, the part that is trying to implement the strategy, because like there is I would say there is often, especially in the NGO sector, a gap that is difficult to address between what we want to implement, the people that are in the field, and then the community. I would say that in general, engaging the community with the front line doesn't seem to be the biggest issue in the cases that I know, but it's more like, for example, using very simple terms, from an HQ to the field, that's it. I would like to understand how to make sure that there is like the right understanding and the right engagement also in between this specific sphere.
It's a very good question. I mean, what I would say is that it's a systemic issue, and I think for civil society, it's about how civil society engages with communities. And so how that engagement occurs, I think, needs to be addressed. So again, how can you take science, knowledge, and reflect on your own practices of engagement, and how can you continuously look at that and find ways to bring authenticity and meaning to the way that civil society organisations engage with their own constituents. At the same time as that is happening, the health sector needs to also work in ways where engagement is authentic and it's collaborative. The business sector needs to do that. So you really need to have a sort of wider lens and approach, and that it's not just one, which goes back to what Pascal was saying, that it's the business of everyone to be able to engage in ways that support well-being and collaboration and partnership building. And I think civil society can offer a way of sort of, addressing some of those dimensions of how communities experience health services. So particularly if there are issues that civil society needs to highlight or address. At the moment, my own experiences has been, you have social accountability mechanisms, you have sort of national policy making processes and priorities, but there needs to be a connection between how people experience the services, how there is social accountability and communities have a voice in saying what changes they need to see happening with the policymakers. And at the moment there's a disconnect between the various pieces that need to come together. And I think there's a big civil society role in helping to articulate those connections so that systems become accountable to communities. Because if communities say we want a change, then you have to find ways of being articulate what those changes are, and somebody has to follow up and say, well, what difference does it need to be made in the way that we provide those services? And so these feedback mechanisms need to be built in. And you're right, they need to be built from the local level up the district level up to the national level. But it's no one person or institution's responsibility. I think we all have to find our part in this. If we recognise that there is a broader imperative here, that community engagement is not just a mechanism to change someone's behaviour or get uptake of a certain intervention. Yes, we want that, but we also want to work in ways that support mental health, well-being amongst all the stakeholders who need to work together. Does that answer your question?
Yeah.
Anyone else? Yes.
Hi, I'm Professor Ku. I come from the IMU, International Medical University. I'd like to reiterate what you have spoken this morning, which is a wonderful talk. I think at the leadership level, being the lead for community engagement in university, what I personally feel is, I think twofold. One, I've inherited a system, what the definition of community engagement has been. And many times it has been, immersed in community service. So that's the mindset. So I'm trying to move further to a wider scope, which I am personally interested in, and trying to engage a larger, proportion of the university. That's very challenging because people tend to think in terms of what it used to be. So that's one. And the other thing is, I want to tap your mind and see what you feel about. Many times when I present or I talk about community engagement, giving well-being, supporting, disease-free, that sort of thing, it's a bit difficult because it's intangible. And when you talk about building social capital, you talk about things like that. It is not such a very good buy-in. I can't get a very good buy-in because it's always been what we need to achieve, like you say, rather than how we do it. People don't tend to see that how we do it, it's just whatever you do it, you just show us what you have achieved. So I feel that's very challenging. I wonder if you have a way. I know it's not a one-person thing. I need to get buy-in. Who needs to sit at the meeting? Yeah, maybe you can share how else I can do it. And we've got 4 of us here.
I can provide you with some resources that would sort of help maybe your thinking and ways of approaching. There's a global transformation which is happening. So if you look at the education sector, it is in crisis. It has its own crisis in terms of is the education sector educating to produce people that are able to be citizens of the world, who are able to live healthy, productive lives, or are they producing students who are able to just be able to get a good job, accumulate enough wealth. So the mindset of the system is important because it determines then how people understand what education is. And we're in the same situation with health. Health used to be focused on we're curing diseases, but now we need to look at sort of how do we promote health, how do we prevent disease. And we know that through research around epigenetics that there are interrelational issues. So it's not only about just disease itself, it's about people's experiences of the world that they lived in that also has an impact of what kind of diseases they get and when those diseases manifest. I think that mindset is a mindset and a paradigm that certain groups of people will be operating under. So you need to operate in a different paradigm, but within a traditional paradigm. And it's always going to be difficult because the people that are in power and sort of work in that traditional paradigm won't want change, because they've spent their entire careers building up a reputation and a way of understanding what science is and the world, and it challenges that, and some people are more open to others. So I think what I found works for me is to identify like-minded people, potential champions, and demonstrate success, because I think if you're able to show impact and results, then that wins over other people, because people want to see, well, what's the difference you can make? But you need to get the kind of support to be able to demonstrate that difference first, and I think that's always the hardest piece is demonstrating that first success. So when we were working with the Ebola, that demonstrated a particular success. With malaria, that demonstrated a particular success. And so you build alliances as you move forward, but it's an iterative process, and I think you've got to it's not going to be an instantaneous is change. And that's with all innovation, that's with all sort of new ways of thinking and different paradigms. You will get innovators, and then once that spills over into the mainstream, you will get people buying into that success. So you've actually got a difficult road ahead of you, but it's also a pleasurable road because there's purpose and meaning. And I think you have to be able to identify stories, use stories to tell of the process and the journey and the result. And so you need to accumulate your stories that will resonate with the different people that you need to get buy-in from.
Yes.
I don't really have a question, but I'd like to share something. I think I'm Priya, I'm from Magna, I'm a volunteer coordinator. I would think the biggest issue would be transitional and gaps. It's not really people don't care, it's not really that. I think, because like, okay, let's say from a university, like me, I get lots of inquiries from students. Like they want to do community service because it's part of the school, the university system or the colleges. So the intention is good. They want kids to be more human, more humane, more compassionate and all that, and more aware of what's happening out there. But when they write in to me, can we do community service, can we do it at weekends at this time? I'm like wondering, do you even know what is Magna? The teacher tells, I want you guys to do this, and you need to do this. Okay, then of course the teacher would have said and some kids wouldn't have heard, that's different. But I would think that transition and the explanation of what is the context of that activity supposed to be. So when I get in calls or emails, I say, do you know what is Magna? They assume Magna is a place where cancer patients are sleeping there and they're taking care of them. Actually, Magna is just an office. We serve the whole community across Malaysia in various ways. So the transition, again, when maybe the top management gets the purpose of this is we want vectors to the wholesome students and all that. And the teacher says, okay, this is something I have to do to me. Maybe there's the engagement from the story, the transitional gaps. So even in every organization, not only volunteer, whatever, just every organization, like she said, visualization and execution is very far. So in between here, you need to engage your team to be passionate about it, not passionate, you believe what you're supposed to do, the purpose, you see the purpose, like it's like it's the meaning and the purpose. So I think that's where it's missing. That's why people get up, okay, I need to go to work. There's no like, okay, today I'm going to do 10 cases. 10 cases, 10 people are going to benefit from my work. So there are followers who are just real, very base followers. I go to work, I do my job, I come back, I just do things. And there are some followers who could be molded. And then those are really leaders, but have not been seen yet or have not been tapped yet. So I think internally we have to strengthen our team, and then we reach out. Then even if you are not in that position anymore, you get transferred to a different department or whatever. The group is strong and it doesn't die. So I think internal, external is a very big thing, but I think we need to strengthen internally. People need to be connected to the purpose and the cause. Of course, the person also is of value level. That person said, I want to do that. But that should not be the main cause. Because if that happens when you change place or you change job, everything goes down the one and everybody has to start again, which is going nowhere in the long term. So I think since most of you here are leaders, I think I'm a normal starter, but most of you look like leaders. So I think as leaders, your team, they need to like you. They need to feel, hey, this person has brains. I want to work with her. That feeling, that relationship, like you'll say your leader is actually having lunch with one person. That's excellent. I would love to work in an environment. I mean, I have a good working environment, I'm not complaining. I have a good working environment, but I'm saying that I would love that kind of a boss. I would love a boss that would listen to me, which I should do have that, thank God for that. I wouldn't want to go through that. But that's what I'm saying. As a staff, what I want. Why I work there and I don't just jump. Why when somebody hands me, I don't jump. Because I believe in what I'm doing. So I think this is what's happening. I think people are not feeling that, and if they do, community engagement will become better. You don't need to tell them, they will do it just because they want to. I think you guys are leaders. Please work on that. I think you're going to have more success. Thank you.
Thank you for that contribution. If anyone else wants to contribute, please feel free. It stimulated two thoughts as you were speaking. One of them is the importance of values. WHO is an organisation. We've got professional ethics. We've got the sort of guidelines that tells us how we need to behave as international civil servants. But we didn't have a set of values. And so over the last year, we've gone through a process of consulting with our country officers and regional officers throughout the world. If we had a set of core values, what would they be and what would they look like? So for the first time, we now have a set of values that we've said are important, that aligns with our goal, with our mission. And now the challenge is, how do we make those values come alive? Because if we say that integrity is important, then how is integrity demonstrated in the everyday relationships and practices and the way that we do our work? If we say people-centered are important, how does that manifest in the way that managers manage their teams, the way that decisions get made? It has to infiltrate every single part of the organisation. I don't know exactly what the proportion of WHO member states have core values, but they do. Member states have core values and they're clearly articulated. And so how do you begin to sort of make sure that leadership, formal leadership with a mandate to lead and be accountable for leadership, how do they enable people to connect with those values? That needs to be part of the work that they do, and it's an important part because it provides meaning and purpose. So the values, I think, is key in being explicit and making sure that the values support what the organisation is trying to achieve. And it doesn't matter whether it's WHO or a civil society organisation. I think institutions, you can tell an institution you can tell the values of an institution by the way that the institution behaves and sees what's important. The other thing that struck me was this leadership can be designated. But if you look at the work of Robert Quinn, who talks about, I think he wrote a couple of books, and one of them was Building the Bridge as You Walk on It, and he talks about leadership being a fundamental state of being. And I think that is open to everyone, no matter whether you are the security guard, whether you are a clinician, whether you are a leader. You don't have to have formal designated leadership to have the attributes of a leader, and we all have that capability. And so he identified 8 components that lead to this fundamental state of leadership, and it's where you operate from your deep essence, where it aligns with your own personal values and purpose. In the context of managing your own environment, and so you're setting a compass for yourself. And I think that's open to everyone. And he came to that by studying real leaders who made a difference, rather than coming from a theoretical perspective and saying, well, there is this theory of leadership, let me go and research it. No, he looked at real leaders and what they did and who they were, and came to this understanding. And I would highly recommend looking at these ones.
The difference between Obama and not allowed. So I'm going to close off here, if that's okay. Can you join me, please, in thanking Asiya? I think just as a very brief summary, I think some of the critical take-home messages, we need the research. We need to think about the research in different ways that inform community engagement, not just as a means to an end, but a means within itself. And that means that we have to think about what evidence can be provided to be able to support that. And the other critical point that I'd put down is that it is everybody's responsibility, and we all need to engage differently for the outcomes that we want. Asiya is here until the end of the year. You've got her email address. We engage, so we would like to hear from you. If we can find ways of working together, that would be awesome. So thank you very much. Makan next door.